If you feel offended by the truth I speak, then you are part of the problem we seek. I say everyone means those who agree, not the ones who take it personally. My take with T.R. Richardson. Say what others think but won't mention. Bold and raw, no filter applied. Join the conversation. Step inside. Think different.
Welcome to My Take with T.R. Richardson. Today, the questions nobody wants to ask. If you've ever been a patient in a hospital, sat beside a hospital bed, or had a parent, spouse, child, or loved one hospitalized, you need to hear this. When we're sick or scared, we put an enormous amount of trust in the people caring for us. Most of us don't know what questions to ask, what records to request, or even what we're looking at when those records arrive. Today, we're going to look at some questions being raised across the country. And I'm going to show you what I learned about how to protect yourself and the people you love. Because information is power. There are some questions you don't want to ask, not because you don't want the answer, but because you're afraid of what the answer might be. Sometimes when something goes wrong in a hospital, there is an explanation. A medication was necessary, a complication happened, a procedure didn't go as planned, a patient was simply too sick. Medicine is complicated, people make mistakes. Not every bad outcome means somebody did something wrong. So when something doesn't make sense, most of us do the reasonable thing. We give the people we trusted the benefit of the doubt. We assume there must be an explanation. We move on. But what happens when you don't get an explanation? What happens when the records don't match? What happens when the medication history doesn't match the billing? What happens when important portions of the medical record are missing? What happens when a family keeps asking for answers and the institution holding the records keeps putting up another barrier? And what happens when you discover that some of the exact questions you've been asking privately are now being investigated by the federal government? That's where this story begins. Not with a conspiracy, not with a theory, with questions. In 2025, federal investigators examined 351 cases involving Network for Hope, an organ procurement organization, or OPO, serving Kentucky and parts of neighboring states. An OPO is the organization responsible for coordinating organ donation and recovery from potential donors. These weren't 351 stories from social media. These were cases examined by the Health Resources and Services Administration, known as HRSA. HRSA is a federal agency that oversees programs involving organ donation and transplantation. Of those 351 cases, federal investigators found 103 with concerning features. That's nearly 30%. Among those were 73 patients with neurological findings that federal investigators said were incompatible with organ donation. Investigators also identified cases raising questions about whether some potential donors were deceased when organ procurement was initiated. The federal findings included concerns about neurological assessments, coordination with medical teams, consent practices, and documentation of causes of death. Now stop there. I'm not saying 73 people were harvested alive. That's not what the federal report says. I'm saying federal investigators found 73 cases with neurological findings that raised serious concerns in the context of organ donation. That's different. And that distinction matters, because if we're going to investigate something this serious, we have to be precise. Then the story gets even more difficult to ignore. The U.S. Department of Health and Human Services, known as HHS, is the federal department responsible for protecting the health of Americans and overseeing major federal health programs and agencies. On August 5th, 2026, the U.S. Department of Health and Human Services, or HHS, announced that it was beginning the process of decertifying Network for Hope after multiple federal reviews found persistent patient safety failures despite corrective actions and repeated opportunities to improve. Think about that.
103,000 Americans are waiting for life-saving transplants. Every one of those donors, every one of those families, every patient waiting for that gift deserves complete confidence that our organ donation system is safe ethical and worthy of their trust.
So now that's the HHS secretary now announcing decertification of a Kentucky organ donation network. Investigators found they incorrectly placed patients on the donation pathway, even those who still showed signs of life.
The government didn't simply say, we have some concerns. There was an investigation, there were corrective measures, there was additional oversight, there was another review, and the federal government concluded the problems had not been adequately corrected. So, the question becomes, what exactly had to happen before the federal government decided that an organization entrusted with potential organ donors could no longer be trusted to meet federal standards? In March 2026, the Centers for Medicare and Medicaid Services, known as CMS, issued new guidance specifically addressing patient protections in the organ donation system. CMS is the federal agency responsible for administering Medicare and Medicaid and overseeing major parts of the nation's healthcare system. The guidance reinforces that patients are supposed to continue receiving appropriate medical care regardless of their potential donor status. It says organ procurement organizations cannot influence the timing of withdrawal of life support or death declarations, and it reinforces that death must be declared according to accepted medical standards before organ recovery begins. CMS also specifically addresses what happens between withdrawal of support and declaration of death, including the responsibilities of the hospital and the OPO, and requires documentation of the time death is declared and the time organ recovery begins. Now ask yourself, why do those safeguards need to be spelled out? Why does the government need to say that an organization involved in organ procurement cannot influence when life support is withdrawn? Why does the government need to specifically address what happens if a patient shows signs of life? Why does the government need to reinforce who is responsible for declaring death? Those rules don't prove that everyone is doing something wrong. They prove that the government recognizes these are areas where safeguards matter, and that should make all of us pay attention. Then there's the money. Let's talk about something else that makes people uncomfortable. Organ transplantation saves lives. There is no question about that. There are more than 100,000 people waiting for life-saving transplants. The transplant system is an enormous medical enterprise involving hospitals, surgeons, laboratories, organ procurement organizations, transplant centers, insurance systems, and government reimbursement. So the question isn't whether money exists in the system. It obviously does. The question is whether financial incentives are sufficiently separated from decisions involving the most vulnerable patients. Congress has been asking that question. The House Ways and Means Committee has investigated OPO Medicare reimbursement, financial relationships, and other financial practices. Congressional investigators have raised concerns about whether the incentives built into the system align properly with patient safety. So now we have another piece of the puzzle. Patient vulnerability, organ procurement, death determination, financial incentives, and documentation. And then we get to something else that seems unrelated. At first, we tend to think of a medical record as a neutral thing. You go to the hospital, something happens, the hospital writes it down, you ask for the record, they give it to you, end of story. Except an electronic health record, or EHR, isn't necessarily one static document. An EHR is the computerized version of a patient's medical chart. Inside that system, there can be an electronic audit trail, which is the history showing who accessed a patient's record, when they accessed it, what they entered, and in some circumstances, what was changed. There can also be metadata, which is information about the electronic record itself that can help establish when it was created, accessed, modified, or transferred. Courts have increasingly recognized that this underlying electronic information can matter when the accuracy or completeness of a medical record is disputed. So here's the question. What happens when the institution controlling the medical record is also the institution whose actions are being questioned? You don't guess. You don't accuse. You examine the underlying data, you compare versions, you look at timestamps, you look at the audit trail, you determine what was entered when, who accessed it, and whether later changes can be accounted for. Because sometimes the most important evidence isn't what the record says. It's what the record's history says. And then Something happened at Harvard. If you're thinking, right, surely an institution would never allow something completely unethical to happen under its own roof. Consider what happened at Harvard Medical School. A former morgue manager stole and illegally sold human remains from donated cadavers over a period of years. Families didn't know. The institution's reputation didn't prevent it. The conduct was eventually exposed through federal investigation. And this month, Harvard agreed to pay $53 million to settle lawsuits brought by families whose loved ones' donated remains were mishandled. I'm not saying Harvard's morgue scandal proves anything about organ procurement. It doesn't. I'm saying it destroys one particular assumption. Something like that could never happen inside a respected medical institution. Apparently, sometimes it can. That's why oversight exists. That's why records matter. That's why transparency matters. And that's why I'm going to change direction now. Up to this point, I've been telling you about things that have happened nationally. Now I'm going to tell you my story. And I'm going to teach you what I had to learn the hard way, because I don't think families should have to go through what I went through just to understand the medical system they're dealing with. And I didn't know what an EHR was. I didn't know what an audit trail was. I didn't know what a medication administration record or MAR was. The MAR is the part of the medical record that documents medications actually administered to a patient, including what was given and when. I didn't know what questions I should have been asking. I didn't know what records I should have been requesting. And I certainly didn't understand how important those things could become after someone dies. I'm going to teach you now because information gives you power. When you're sick, frightened, exhausted, or sitting beside a loved one who can't speak for themselves, you should not have to become a medical record expert overnight. You shouldn't have to learn everything I learned through nearly 2 years of fighting for answers. My goal is to give you the vocabulary, the questions, and the tools before you need them. Because you don't have to be a doctor to advocate for a patient. You don't have to understand every medical term. You just have to know enough to recognize when something doesn't make sense. Document what you're being told and ask another question. And if someone makes you feel stupid for asking a reasonable question, that doesn't mean you're stupid. Ask the question again. Ask for it in writing. Write down who told you what and when. Bring another person into the conversation when you can. Keep your own timeline. Keep copies of your records. Don't rely on memory when you can document something. Information doesn't make you anti-hospital. Information makes you an informed participant in your own care. And now I'm going to tell you what happened to my husband. My husband's name was Kenny Edmonds. In November 2024, he went into the hospital. He came out alive. He did not come home healthy. Over the months that followed, his condition deteriorated. Eventually, he developed organ failure and died. I believe the care he received during that hospitalization caused or materially contributed to the injuries that ultimately led to his death. But that's not where the mystery begins. The mystery begins with the records. I requested my husband's medical records, then I requested them again, then again. After my third request, I was told I needed a court order. Think about that. A wife was asking the hospital that treated her husband to provide his medical records. Eventually, records were produced, so you might think that was the end of the problem. It wasn't. The records were incomplete. Important medication administration information was missing. And as I continued digging, I discovered something even more troubling. I wasn't dealing with one consistent story. I had different versions of my husband's records from the same institution, different information, different gaps, different documentation. And that changed the question. At first, I was asking, what happened to my husband? Now, I was asking, why can't the records tell me what happened to my husband? Then I started comparing what was documented with what was billed. Some medications appeared in billing information that I could not reconcile with the clinical documentation I had received. Other information appeared in one record set and not another. There were significant gaps in documentation during periods that were medically important. There were medications that, when you put the surviving records together, raised serious questions about why they were given, when they were given, and what effect they could have had on a medically vulnerable patient. Some of those medications have legitimate ICU uses. That matters. I'm not saying a medication is evidence of a crime simply because it can be used in another context. I'm asking a much more basic question. Where is the complete record showing what Kenny received? When he received it, who ordered it, who administered it, and why? Because if the medication administration record is missing, you can't simply tell a family, trust us, everything was appropriate. The record should be able to demonstrate it. There was also a narrative in Kenny's medical record portraying him as a current drug user and suggesting that his condition was attributable to that. I disputed that characterization, the family disputed it, and I began wondering, was this simply an inaccurate assessment? Was it a clinical mistake? Was it a misunderstanding? Or did that narrative become the explanation for what happened to him? Again, I don't want you to assume the answer. I want the evidence. Because a medical narrative is not the same thing as proof. If someone says a patient was dying because of drugs, I want to know what toxicology supported that, what medications were actually present, what the vital signs were, what the neurological examination showed, what the imaging showed, what the laboratory data showed, what the medication administration record showed, and when that narrative was entered. Those are answerable questions. By this point, preservation of the records had become a legal issue. A federal judge had reminded the hospital of its preservation obligations. Then the hospital began moving its old computerized medical records from Cerner into a new system called Epic. That process is called an EHR migration. Let me be very careful here. An EHR migration does not prove somebody destroyed records. Hospitals change electronic systems. That's normal. But when the preservation of disputed medical records has already become a legal issue, the underlying legacy data becomes extremely important. You would want to know, was the original Cerner data preserved? Were the audit trails preserved? Were the access logs preserved? Were the original timestamps preserved? Were modification histories preserved? What happened during the migration? What was transferred? What wasn't? And can the new system reproduce the original information accurately? I asked for the underlying electronic information that could show when records were created, accessed, changed, or transferred. That information was not provided to me. And the complete record still has not been provided. I want to make something very clear before we go any further. I wasn't asking for Kenny's records as a stranger, and I wasn't asking for information I had no legal authority to obtain. I was his wife, and after his death, I went through the legal process of being appointed to represent his estate. I was issued letters testamentary, which established my authority to act on behalf of his estate. In other words, when I was requesting records and information belonging to Kenny's estate, I had legal authority to make those requests on his behalf. That included the medical records, the medication administration record, the underlying electronic information, the audit trail, and the other records I was requesting. I wasn't asking the hospital to give me something that belonged to someone else. I was asking for records belonging to my deceased husband, for which I had established legal authority to act. So when I tell you that I repeatedly requested these records and that I continued to receive incomplete information, I want you to understand that this wasn't simply a case of a wife asking for something she wasn't entitled to receive. I had gone to court, established my authority, and I was still asking for the records necessary to understand what happened to him. Now ask yourself, is that proof of a conspiracy? No, it's a clue. And that's when I started looking outside my own case. I started looking at what was happening nationally. That's when I found the federal investigation into Network for Hope. I found the 351 cases, the 103 concerning cases, the 73 patients with neurological findings federal investigators found incompatible with donation, the concerns about death documentation, the concerns about consent, the concerns involving neurological assessments and coordination with medical teams. Then I found the congressional investigations. Then I found the new CMS safeguards. Then I found the federal decertification. And suddenly, questions that had seemed almost impossible to ask didn't seem quite so impossible anymore. Not because the government had proven my theory, it hadn't. Because the government had proven something else. The system is capable of failing in ways that can put vulnerable patients at risk. That changes the question. When a person is unconscious, sedated, neurologically injured, intubated, or otherwise unable to advocate for himself, he is extraordinarily vulnerable. He can't question the medication. He can't question the diagnosis. He can't challenge the doctor's conclusion. He can't tell his family what he is experiencing. He may not even be able to communicate that he is still aware. His family may be frightened, overwhelmed, and completely dependent on the people inside the hospital to tell them what's happening. And the hospital controls the medical record. So ask yourself, who protects the patient when the patient can't protect himself? Who checks the medications? Who checks the neurological examination? Who checks the death determination? Who makes sure the family understands what is happening? Who makes sure withdrawal of support decisions are independent? Who checks the records afterward? Who checks the electronic history? And who checks the people who are responsible for checking all of it? I tried very hard not to go where this investigation eventually took me. I made excuses. I looked for other explanations. I wanted this to be bad medicine. I wanted it to be incompetence. I wanted it to be mistakes, because those things are horrible enough. But after nearly 2 years of examining what happened to Kenny, I believe something more deliberate happened. I believe Kenny was targeted. I believe the treatment he received in November 2024 was intended to place him into a condition in which life support could be withdrawn and organ procurement could potentially follow. I cannot prove that conclusion yet. I'm telling you that because I don't want to pretend I have evidence I don't have. What I do have are the clues that led me here. The treatment, the medications, the objections, the records, the missing medication administration information, the billing discrepancies, the gaps, the different versions of the record, the narrative about my husband, the repeated difficulty obtaining the records, the preservation issue, the electronic record migration, the missing underlying electronic information, and now, outside my own case, a federal government investigating many of the same categories of concern inside the organ procurement system. That's why I'm asking the question. I'm not asking you to believe me. I'm asking you to think. Maybe there is a completely innocent explanation for every discrepancy in Kenny's records. If there is, I want it. Maybe the medications were all clinically justified. Then show us. Maybe the missing documentation exists somewhere. Produce it. Maybe the different versions of the records can be completely reconciled. Reconcile them. Maybe the EHR migration preserved everything exactly as it should have. Then show the audit trail. Maybe my theory about Kenny is wrong. I hope it is, but if it is wrong, the evidence should be capable of proving me wrong. That's what an investigation is supposed to do. And there are other families. Since I began speaking about this, families have come forward with their own stories. More than 1,000 people in my broader community have shared stories of loved ones they believe suffered preventable deaths or received treatment they could not understand. I am not going to tell those families that their loved ones were targeted. I don't know that. And I don't want them starting with my conclusion. I want them starting with their timeline. What happened? When did it happen? What changed? What medications were given? When did consciousness change? When did the family first hear that the patient might not survive? When was withdrawal of support discussed? Was organ donation ever discussed? Was an OPO involved? What records were requested? What records were received? Did the records agree? What happened immediately before the patient's condition changed? What happened afterward? Or preserve everything. Because maybe there is no pattern. Maybe these are 1,000 separate tragedies. But if there is a pattern, we need to know that too. And the only way to determine that is to stop arguing about theories and start comparing evidence. This is where I believe the Edmunds Act comes in. I believe we need stronger protections for patients who cannot protect themselves. Not because every doctor is corrupt. Not because every hospital is corrupt. Not because every OPO is corrupt. The vast majority of healthcare professionals go to work trying to save people. That is exactly why the safeguards should be stronger. The Edmunds Act should create meaningful protections around medical record access, preservation of electronic health records, audit trails and metadata, medication administration records, documentation of family objections, independent review of disputed deaths, clear separation between treatment decisions and organ procurement interests, transparent documentation of death determinations, and an independent mechanism for families to challenge incomplete or contradictory records. I'm asking lawmakers to look at it. I'm asking someone with the ability to sponsor it, to step forward. Don't take my word for it. Bring in physicians, bring in nurses, bring in transplant professionals, bring in medical ethicists, bring in attorneys, bring in patient advocates, bring in the families, tear the proposal apart, find what's wrong with it, make it better, then put real protections into law. So this is where I'm going to leave you, to HHS, to CMS, to HRSA, to Congress, to state regulators, to prosecutors, to investigative journalists, to anyone whose job is to protect patients who cannot protect themselves. Look over here. I'm not asking you to adopt my theory. I'm asking you to investigate the evidence, look at the medications, look at the timelines, look at the billing, look at the medical records, look at the audit trails, look at the death determinations, look at the OPO records, look at the financial incentives, look at the families, and then tell us what you find. Because maybe this investigation ends with an innocent explanation. Maybe Kenny's case is terrible medical care, documentation failures, and a series of mistakes. If that's what the evidence shows, I'll follow it. But if the evidence shows something else, we need to know. Because one patient deliberately targeted is one too many. One patient prematurely written off who could have survived is one too many. One family denied the truth about what happened to someone they love is one too many. And one preventable death that nobody investigates is one too many. I didn't want to believe any of this. I fought against the idea. I looked for another explanation. I kept asking for records because I wanted the records to prove me wrong. Instead, the questions kept getting bigger. And eventually I realized something. The most important question isn't whether you believe me. The most important question is whether anyone is willing to look closely enough to find out. My husband's name was Kenny Edmonds. He deserved that investigation. Every patient deserves that protection. And if somewhere in this country there is even one patient who was deliberately targeted because he was vulnerable, unconscious, and unable to speak for himself, one is enough. Let's find out. You can find out more information on the EDMONDS Edmonds Act at wematter.life, and you can sign the petition for sponsorship there or at change.org. I am T.R. Richardson, and that is my take. If you enjoyed my take, please like and subscribe. Forward to some others out there that may think they are alone. They are not. We are still the majority. We just have to stop being silent. See you next time.
Walk in the ward, dollar signs on your skin. Age, history, insurance, that's how they begin. If your body's worth more than the plan will pay, you become a ghost for the harvest. Yeah, that's the play. Great coverage, they'll script you a lie. False diagnosis, med stack high. Drop you, mistreat you, silence your breath. Don't talk too loud or you'll never leave death. Homeless, done, addict done. Vest with good insurance, they target everyone. Guardianship papers, control of your fate. Tanny County numbers on CaseNet. Look and see they all relate. Systemic cover up, scroll down from the top. Speak up, your silence, they'll make you stop. But hear me now, hear me clear. Silence is the killer, we got nothing to fear. Wake up, people, the truth's in sight. Profits over patience, they scrub records for a court fight. Murder my love, now they fear my pose. I'm not the only one spitting truth, they harvest goals. I know walks got 2 R's not in it. They exaggerate fake accolades, but the numbers don't lie, my friend. Yeah, they'll script you a lie, stack meds to the sky, drop you, mistreat you till your last breath dry. Guardianship chains, fade in their hands. CaseNet codes, Taney County, all part of their plans. Homeless addicts, vets with good plans. They target us all, it's part of the scam. People, the truth's in sight. Profits over patience, they scrub records for a court fight. Murder my love, now they fear my pose. I'm not the only one spitting truth, they harvest gold. On the walks got 2 R's not in it. They exaggerate fake accolades, but the numbers don't lie, my friend. The numbers don't lie, my friend. Silence is what's killing us. We got nothing to fear. Save a life, speak your truth, let's make them hear. Strengthen numbers, strengthen voices, join the fight. Time to serve them up, they could be the courses tonight. Yeah. Harvesting goals, yeah, that's their game, but we're gonna